All right, thank you very much. The meeting is now being recorded. After the meeting, it will be posted on the commission's webpage shortly after the meeting, not immediately, but it will be there. And TVW is also streaming this meeting live and archiving it. So that's an additional way that folks can watch the meeting later if they want to. For everyone's reference, the agenda is under the first tab in the materials. And now I will turn it over to Vicki Lowe, Chair of the Universal Healthcare Commission, who will now call this meeting to order.
Thank you, Mary. It is now 2:02 and I call the October 10th meeting of the Universal Healthcare Commission to order. I would like to begin by doing a land acknowledgement, but I have lost it. Sorry, I have a new computer. Okay, well, I'll just, we've had a lot of conversations with the tribes lately about land acknowledgements and some of them not being really meaningful. And so I have a land acknowledgement that I drafted. Sorry. And I just want to take a couple seconds to talk about it. So land acknowledgements began as a way to kind of help understand the idea that land was taken from Indigenous people and that we all live on Indigenous land. And I think for us, as we look at healthcare, I think it's really important to understand that the impacts of that removal of American Indians, Alaska Natives, mostly American Indians, from their land, and the other things that happened in the history of the relationship between our people and the federal government, and that they have had a huge impact on health disparities of American Indian and Alaska Native people. And I say these things not because I want people to feel like bad or shamed. We say these things because it's important as we address healthcare, and especially as we're looking at the healthcare system in Washington State and trying to make it more responsive to all Washingtonians, that we understand that people were harmed by the inequities in the past. And as we build a new system, that we really need to be looking and making sure that we're centering the work that we do on our most vulnerable people and people who have had those kind of impacts. So I'll just leave that there for now. But I want to give a warm welcome to everybody for joining us today. And also we get to introduce new staff today, which is great. We have two new staff members. We have Todd Bratton and Allie Power, and they are the health policy analysts who will be supporting the work of the Universal Healthcare Commission and the Financial Technical Advisory Committee. But I also have to share that Mandy is leaving us, and Mandy has been, part of the Universal Healthcare Commission from the beginning, and she's moving on to a new job, and we just want to express our thanks to Mandy for all of the great work that she's done and the support she's given to the commission and the staff. I know she's personally helped support me with so many things, with getting ready to do presentations to the House Health Committee. And, I've known Mandy since she was working at the OIC, but I just want to wish her well. And Mandy, I don't know if you want to say anything.
I'd be happy
put you on the spot.
No, I just want to say that it's been a pleasure and an honor to work with the commission and with you and the other members and all the stakeholders involved in this work. And it's just been a real privilege to be a part of this effort.
Thank you.
Thank you, Mandy. Okay, and with that, we will move on to the agenda. So if you go to the tab 1 in your documents, and if we're on the next slide, we'll start by doing a brief overview of the agenda. First, we'll have roll call, and as part of our getting to know each other effort, today's questions will be, as we enter the darker days of fall and start spending more time indoors, what's a book, movie, or podcast you are recommending? After roll call, we will vote to approve the August meeting summary. Then we'll open the floor to public comments. After public comments, Liz Arjun of HMA will provide a brief update on our progress. We'll hear from the Financial Technical Advisory Committee, including the discussion and potential vote on cost-sharing principles from Pam McEwen, who is our liaison with that committee, and Mary Franzen, who's staff of the Healthcare Authority. And then after that, we will vote to approve the 2024 annual report to the legislature. Following the vote, we will have our state agencies report outs. And then we'll revisit the Apple Health Extension discussion we had in August. So we have Becky Carroll back from the Washington State Healthcare Authority to talk to us. Next, we'll hear from our commission member, Jane Beyer, about the Office of the Insurance Commissioner Healthcare Affordability Report with time for questions and answers. Following those presentations, we'll take a short break. And then when we come back, Gary Cohen and Liz Arjun of HMA will lead the commission in further discussion and potential votes about prior authorization, and as well as the next steps in our work. So now I'll turn it back over to Mary to go through roll call.
Thank you, Vicki. Good afternoon, everyone. I'm going to call members by the first name in the order listed on the agenda, which is alphabetical order by first name. When I call on you, please unmute your microphone and let us know you are here. And I'll repeat the question. We are headed to the dark days of fall and winter. So what's a book or a movie or a podcast you recommend for the upcoming seasons? So Chair Vicki.
I am present, and boy, I'm really struggling to think. I don't know if I've already outed myself as a Trekkie, but right now what I'm doing is I found a list of how to watch all of the Star Trek shows in chronological order. And so that's what I'm doing this fall, and there's quite a bit.
I will see you at the next convention.
Senator Ann. Senator Ann. Vidisha.
I'm here. I don't know if I have any recommendations, so I'm eager to hear others' recommendations so that I can maybe catch a movie or two. I do like watching all the KSBS, PBS murder mystery shows, so maybe that's all I'll do in the dark.
Charles. Charles.
But he's having difficulties. I think he's moved in and out a couple times. Give me just
Okay.
1 second. I'll try and get him back
Okay.
into the room again.
Maybe having slight audio
He's having
difficulties there.
difficulties there.
We can come back. Dave.
He's also moving into the room as well.
All right, we'll come back to those two. Senator Emily. Jane. Okay. Joan.
Okey doke. I was waiting to get promoted to be a
Oh.
panelist. Good afternoon,
Jane.
everybody. Good afternoon, and podcast. If anybody ever listens to Throughline, it is an awesome podcast because they take issues that are there now and go back and provide a great historical context. It's called Throughline.
Now Joan.
Hi all, good to see you present. Preoccupied now that it's getting dark with chasing every time they say you can see the northern lights from Washington. I try, and every time I fail. In terms of so I will try again tonight. Apparently they're supposed to be visible tonight. I am watching the new Matlock with Kathy Bates in it, which is kind of entertaining and fun for anyone who likes either Kathy Bates and or murder mystery types of things. So plan on watching that through the dark days.
And we'll jump back up in the alphabet for a moment. Charles.
I would say rather than having a favorite, I would encourage everyone when you're driving in your car and have to log hours in your car, be listening to audiobooks, be listening to podcasts, make that time worthwhile. Because I have to drive a lot just because the size of district. And I find that it's very refreshing and interesting to find your favorite book and podcast and pass the time driving listening to that. So don't waste that time in the car. Use it for productive purposes. That's my encouragement.
Representative Marcus.
Hello, everybody. I am present. I just started Cold Millions, which is by Jess Walter, who's a Spokane author, but award-winning, and it kind of weaves fiction in with historical things, and it's got, at least the start, a very wintry feel. So that's what I'm going to do. Did I miss something I was supposed to answer to? I'm sorry.
That's good. It's a great book, actually. I've read it.
Oh, awesome.
Mohammed?
Hi everyone. I also proud to listen or read a lot of history books. My favorite is a book called *Sapiens* by Yuval Noah Harari. I'm gonna put his name on the chat. I butcher his name. Yeah, that's a very good book. It's a lot of good history, and I'm gonna pass it to you.
Nicole?
Hey everyone. Let's see. I typically, when I'm driving, which I do quite a bit, much like Representative Schmidt all over the state, I like to listen to audiobooks, mostly relating to economics, which is kind of a weird thing, but I really like to listen to those nonfiction books while I'm driving.
Omar? Omar? And Stella? Stella? And we missed two folks and their recommendations, so we'll go back. Charles?
Yeah, agree. Charles Tim here, and agree 100% with the recommendation on audiobooks. They really helped me catch up with a lot of readings I've been wanting to do of recent. Currently, I'm reading The Social Transformation of American Medicine by Paul Starr, and it's a highly recommended read for members of the commission, really, to really understand how we got the healthcare system we have today and the different decisions that have been made. It's really important to read that book to kind of get the history and the journey to know how we might do things differently in the future.
And Dave?
Hi, everyone. Present. Thank you for circling back. Gave me a moment to think about this. There's a book that I try to read every couple of years because it's just had a lot of influence on me and my Flowers for Algernon. Many people have heard of it as a short story or seen the film, but the experience is absolutely not the same in a movie versus a book on this one. I know people say that all the time, and I'm not saying one is better over the other, but the experience is very different. It's a lot about ethics and research, and it's really a first person telling of an individual who has significant intellectual cognitive issues, and his writing style that you're experiencing as you read, as he transforms into this highly intellectual person and then loses that capacity again in that second half of the book. The rise and decline in the writing style is really quite it's its own experience, and I've never read any other book that's quite like it, and it just reminds me of the wide range of human experience that exists and is in the population that we serve, the membership that I serve in the PEV&SEB program, and it just reminds me of so many important things that need to be taken into consideration in all the work that we do as public servants. So, Flowers for Algernon. And unfortunately, it won't be the same experience in audio. So that one you really should read.
Thank Thank you, everyone. I'm going to turn it back over to Chair Vicky, who will facilitate a review of the meeting summary from our August meeting.
Yeah, all right. Thank you, everybody, for those answers. I was quickly writing stuff down. So if you turn to tab 2, there's the recording of the last meeting is posted on the website or the webpage. And just looking for a motion to approve these minutes, or if there's any discussion. Is there any comments or changes need to be made?
I'll move to approve.
All right, we have a motion from Jane. Do we have a second?
I second.
Thank you, Vidisha. So we have a motion and a second. Is there any other discussion? All right. All those in favor of approving the minutes from the August meeting, say aye. Aye.
Aye.
I
Any opposed? All right, thank you. Now we'll move on to opening the meeting for public comments. Public comments received since our last meeting can be found under tab number 3 in your meeting materials. We allow individuals to sign up to provide public comments before the meeting, and we will start those with those who have signed up prior to the meeting. If you have not signed up and would like to provide public comment, please raise your hand. Mary will call on you after we hear from the individuals who had signed up. When you are called upon, please state your name and any affiliation before speaking. Please do not raise your hand more than once. This helps to ensure that everyone has a chance to speak. You are also welcome to provide comments in writing via email at any time. We all get those. To ensure that everyone has a chance to speak, there's a limit of 90 seconds per person, which may be reduced if we get closer to the time limit for public comment. And there are numbers of others who wish to comment. We will be displaying a timer as a reminder of the limit. When the timer stops, please wrap up your comments. We encourage public comments to be focused on the materials that are being discussed today. We may run out of time for these comments. If we do, you are welcome to submit those comments in writing, as I said before. So Mary, would you please start with the names of the individuals who signed up?
Thanks, Vicki. We had 2 people who signed up ahead of time. We will speak in the order in which they signed up, and our first person is Marcia Stedman.
Okay, took a while to join as a panelist. Good afternoon, everyone, and thank you for this opportunity to speak today. My name is Marcia Stedman, and I'm a volunteer with Healthcare for All Washington. And as a member of the public who has spent considerable time and energy following the commission meetings these past 3 years, I am disappointed to not see clear recommendations for transitional solutions to the legislature in this report. Solutions that could ease the transition to a universal system while addressing our state's crisis in healthcare access and affordability. As a volunteer with Healthcare for All Washington and a member of a broad coalition of universal healthcare advocates, I call your attention to the letter from Healthcare for All Washington President Ronnie Shore on pages 12 through 14 of your agenda packet. Studies exploring 3 of the transitional solutions listed in the table on page 56 of today's packet either are or will be completed by December 2024 of this year. These are solutions that were identified last year, and it's time to act on them. So, I have a question for the legislators here today. Would you be willing to sponsor legislation to implement the transitional solutions identified in the letter from Healthcare for All Washington? That is, expanding access to Medicaid for the low-income individuals that are on Medicare now, consolidating PEB/CEB public programs for healthcare purchasing, and creating and funding a Medicaid to Washington Health Benefit Exchange enrollment bridge. along with Apple Health expansion on today's agenda. Thank you.
Thank you. The second person who signed up to speak is Catherine Lewandowski.
Hello, members of the Universal Healthcare Commission. My name is Catherine Lewandowski, Board Vice Chair of Paul Washington. We do very much appreciate the efforts of the Commission and especially of the Healthcare Authority for their support of the Commission. I also have to say that I so appreciate all of the volunteer efforts of Andre, our Executive Director, and for so many of our whole Washington volunteers that have helped in this work. And worked diligently over the last 3 years to educate and inform you about what we want and need in our healthcare financing and delivery system. As an organization whose philosophy from our inception has been that a comprehensive, inclusive, affordable, universal, nonprofit healthcare system for all residents of Washington State is both feasible and economically wise and politically attainable, even within our current federal legal restraints. A system that would be an exemplary example for other states to emulate as they also try and rescue as many of their citizens as possible from our current predatory system. I just have to say thank you. You have effectively proved our point. I feel this will only happen as a ballot initiative where our state residents will be able to tell our government that we choose life, liberty, and the pursuit of happiness, fought for and guaranteed to us by valiant men and women who were tired of the chains of a king and his dynasty. We and our employers are tired of being kept in a chokehold for a for-profit scheme that does not save us money, does not reimburse our providers adequately, does not control costs, does not deliver us effective and timely care in order for us to achieve said life, liberty, and happiness that is the promise of America. Thank you for all you have done. We fully understand that you are being held in that same chokehold. Truly, our goal is to rescue you also from your chains.
Thank you very much, Catherine. Thank you. Our next speaker is someone who is Maureen Brink-Lund. And in parentheses, it says Mo, so I'm not sure which name you prefer.
Well, thank you very much. Mo is fine. And my name is Maureen Brinkland, the longer name. And I affiliate with Healthcare as a Human Right. And I haven't been at one of these meetings for several months now, but I've been listening in for years, literally. And I also affiliate with the League of Women Voters. And I'm just here today specifically to remind everyone about the work that preceded this commission, the Universal Healthcare Work Group. And I'm often mindful of the report that they put out, which I went and took a look at. And I hope all the commissioners and the consultants on this group have delved into that report, because it does call out the things that you're struggling with and doing now. And what I've found from the very beginning of these meetings is there is a lack of vision. We don't know where you're going. I'm not sure you do. So how you do your work is amazing to me. But and the section called Achieving a Vision of Universal Healthcare System ends with these, or starts with these words: to achieve universal healthcare will require the legislature, governor, state agencies, and a range of stakeholders to engage in a series of staged activities that will likely require many transition steps. This includes choosing one model, defining detailed operational plans, and establishing policies to ensure the health reform goals are achieved. I would love to be able to talk to my fellows in the community about the model you've chosen, whatever that is, but it's lacking. So thank you very much.
Thank you. I'm not seeing any other hands raised. And so I think that concludes our public comments.
All right. Thank you very much for those comments. And next, we will be moving to a project status update from Liz Argent from HMA. Liz?
Hi, can you hear me?
Yes.
Good to see you all. Audrey, are we gonna go? Yep, got it. Great. And so really my goal here is to just, because we have big spaces between our meetings, to just make sure everyone's grounded in where we've been, where we're going, and what we're doing today. So if we can go to the next slide, Audrey, that would be great. Just to remind folks, we shared this slide back in, I believe it was in June, just really trying to convey that there's 3 work streams that the commission is focusing on. The first 2 were part of the authorizing legislation, and then the third one, request from a legislator last year. So first work stream is the designing the universal healthcare system. Second is recommending interim or transitional solutions to help folks now and contribute to the future design. And finally, the third request was the reviewing and comparing with the Washington Health Trust proposal. So just reminding everyone of that piece. So if we can go to the next slide, Audrey, thanks. So on workstream number 1, if you may recall, we talked about this in our inaugural report. There's really 3 phases to the work. Phase 1, which is really grappling with issues like benefits and services, eligibility, financing, cost containment, provider reimbursement. Phase 2 would be our infrastructure and enrollment, and the phase 3 is focusing on governance. And we've really been in phase 1 for the last couple of years. So I'm going to just talk specifically about that piece and what we're doing today. Audrey, can we go to the next slide? Thanks. So just a reminder, last year we talked about eligibility, and if you all may recall, we talked about Medicare, we talked about ERISA-sponsored plans, we talked about Medicaid, and who was going to be included in the group at the initial start. And the decision was that right now there's not a feasible pathway for self-funded plans in Medicare, but the commission did say that they were very interested in trying to achieve parity for those groups of individuals after we started with the Medicaid and other populations that we can control, including the exchange populations and large and small group populations. After that, we started this year, we focused on benefits and services and quickly pivoted into the conversation about cost containment and cost estimates, really trying to understand that because they couldn't be teased apart. And the idea is that by looking at eligibility, which we've already done, the benefits and services, talking about provider reimbursement, participation, and cost containment, we could come up with some cost estimates and ultimately talk about how we were going to finance this new universal system. So today, we, as I said earlier this year, we talked about benefits and services and moved into conversations about cost containment, provider reimbursement, and participation, but also started really talking about cost sharing with the FTAC. And so today, if we can go to the next slide, Audrey. The conversation is really going to focus on cost sharing. So if you may recall that back in July, the commission heard recommendations from FTAC to move forward with some selected benefit packages to model, including the existing assumptions around cost sharing. So that decision was made in July, and currently HCA is in the process of contracting with Milliman to come up with those estimates. In the meantime, there are several components that, including cost sharing, provider reimbursement, and cost containment, that we would like to talk about layering on in the future design. And so the first one of those is cost sharing. And today, the FTAC is bringing forward some principles to all of you to discuss about how they should be thinking about that in their design for the future system. Okay, let's go to the next slide. For workstream number 2, just a reminder, the transitional solutions or interim solutions. Last year and at the beginning of this year, there were 3, after consideration of, through interviews and conversation last year, settled on 3 larger buckets of issues, some of which were mentioned in public comment today. First was administrative simplification, and we've been focused on that this year, and have kind of winnowed down from a big picture, several options and areas to focus on administrative simplification, and then narrowed into a focus on prior authorization. The other large bucket that we talked about was maximizing, leveraging, and expanding current programs. And today we're going to specifically talk about what's going on with the expansion, Apple Health expansion for undocumented immigrants, which already, as we'll hear today, has started and is already in a waitlist mode. So want to hear about that. And then today we want to talk about next steps and what might be another area that we want to focus in. And I heard a public comment about Medicare savings program. So, and the consolidating and expanding state purchasing. So that's a conversation during our next steps at the end of our meeting today. And that, just to kind of, again, remind you of how we got to the focus. We started out in February with the big picture of administrative simplification. We heard about HCA's ongoing efforts. We heard from One Healthport and the work they've been doing in the state on that. We heard from several providers in June about how administrative simplification could help them in the work that they're doing. And then back in August, we focused on prior authorization. There were some draft considered recommendations in August, but because there was no quorum, there was no vote on that. And so today we're revisiting that. And again, we're going to hear from Becky Carroll and folks at HCA on what's going on with the expansion for immigrants in Apple Health. All right, and I'm going to turn it back over to you, Vicki.
All right, thanks, Liz, for that update reminder. Our next speaker is Pam McEwen, who is our liaison to the Financial Technical Advisory Committee, and Mary Franzen, who is staff to the Healthcare Authority. Pam and Mary?
Yeah, thanks, Vicki, and good afternoon, everybody. I'm happy to walk you through some of the work that EPTAC has been engaged in, and also to get your kind of input and comments on some of the principles of cost sharing that we're going to bring forward. The first slide, please. So it's really helpful to follow Liz, because as you go kind of back into your memories of work that you've asked us to do, we have been continuing to work on analyzing the cost and cost sharing models. Again, looking at the benefit design of three, kind of almost what you would think of as benchmark plans to compare those benefits and to look at some of the variables that occur. Primarily, cost sharing is a big issue, but also benefit design and what the constellation of benefits are. We had, at our last meeting, we had presentations and really robust discussions about cost sharing during a July and September EPTAC meetings. This has been kind of a significant issue, I think, with the commission and with many of the stakeholders that we've been hearing from. There was a decision to engage Milliman to model the cost sharing scenarios and the benefit design. And then we also kind of took another step forward to kind of develop a list of principles of cost sharing as a way to think about it. It will impact how these various benefit designs impact consumers, but also overall costs. And so it's just a way to think about it as you grapple with those issues in the future. So Milliman will be modeling cost sharing scenarios for the population assumed to be eligible to enroll in universal coverage. And I think Mary was teed up to talk about our next two slides. Am I right about that, Mary?
Sure, I can jump in. Thank you, Pam. Yes, they are modeling cost sharing. If you think back to Liz's slides a few moments ago, she had a gold box talking about looking at cost sharing. And so this work resides in that gold box. And the first thing I want to talk about is the population that we are looking at in the analysis. And population is singular on purpose. We're talking about a group of people defined, as Pam just said, the people we assume would be eligible to enroll in universal coverage in Washington. So that's age 64 and under, not in Medicare, TRICARE, VA Health, or an ERISA qualifying plan. So that's the population we're looking at.
Jane, did you have a question for now?
You're on mute. There you go.
Yeah, I really wanted to clarify this. ERISA, an ERISA plan can be both fully insured and self-funded. I think that the decision of the commission was to say that it was not enrolled in a self-funded group health plan, and that is very different than an ERISA qualifying plan. And also on this includes, I think what we want to say is this includes the uninsured, public employees, school employees, fully insured markets, parens, individual, small group, large group, and Medicaid. I think because that Milliman will understand. If you say those words to Milliman, Milliman will understand it.
Thank you. I think you're
Jane, I
as,
just have
yeah, as usual, you're right.
Thanks. You know me, I'm beating this dead horse to death, but I want people to understand it.
No, that's helpful.
Thank you.
And Jane, just as clarification, I do believe we have on the list also an opt-in option for those that are not.
For self-funded group health plans. Yeah. I mean, yep, you could definitely say that. Yep. But I think we just need to all remember that ERISA governs group health plans, which can either be fully insured or self-funded. And here, the discussions that we've been having relate to self-funded health plans being out and fully insured health plans being in.
Yes.
Thank you.
Thank you. Okay, next slide, Audrey. So in order to look at the benefit packages for this population, and thank you, Jane, for the clarification, they will model cost sharing scenarios for these identified benefit packages for the identified population. Looking at Medicaid, looking at PEB-SEB, and looking at Cascade Care Silver. So this is a very high-level table of how they are going to model it with the cost sharing for this population for these three different plans. That is what they're going forward on, and the work is beginning. And I think those are my only slides, Pam, but I'll pause to see if anyone has further clarification on that.
Jane, I see your hands up.
Oh, sorry, Jane, I missed it.
No, I think
I forgot to lower it.
Okay, that's another Zoom thing that happens all the time.
Okay, well, I think it goes back to you now, Pam. Thank you.
Okay, next slide, please. So, looking at those, and obviously it stimulated a lot of discussion about cost sharing, and there had been a significant discussion amongst the commissions. So, we spent at least a meeting really kind of inundating ourselves with information about this. And I think many of you are also really familiar with kind of current discussion about cost sharing, but it's an area which is evolving because cost sharing has changed a lot. I think initially we can think back several years where cost sharing had a lot to do with impacting people's utilization or steering people towards preventive care and away from the emergency room. But what we've seen in recent years is there's been so much cost sharing towards consumers that it has begun to impact utilization. So the FTAC tried to really deal with both things, looking at how this has evolved, what we're seeing in studies, and how this might be moving forward, and also to think about how to deal with a lot of confusion on this topic. There's probably as much detail as you can stand that's in the PDF in your meeting packet. Next slide, please. We thought it could be helpful to develop kind of a list of principles as a way to think about cost sharing. So really the most significant number one is to seek cost sharing arrangements that do not create barriers to care. I think research on this is mixed, but I think there's current research to show us that people are finding cost sharing to be a significant barrier to care in many circumstances. To identify selective services and think about selective services such as preventive care or diagnostic screening that would not be subject to cost sharing at all, to never pose any barrier, and also to encourage people to seek those services. To vary cost sharing requirements based on individuals' income. Currently, we see this in Medicaid and exchange plans, which is there's minimal or zero cost sharing for those individuals. And in looking at universal systems in other countries, we learned that many of those nations, or through health plans or through a national system, set limits so that people who are lower income do not have any cost sharing. Next slide, please. Then this is this 4 is important, maybe tougher to achieve, but is to create cost sharing structures that are simple, predictable, transparent, and easily understood for individuals seeking care. And we might even think of an amendment of having it be those same characteristics being there for providers as well, because if providers can't understand your cost sharing, it's really hard for them to diagnose your treatments. And then to review the commission's final policy decisions through kind of the lens of the Health Equity Toolkit. And finally, to review and revise cost sharing designs as medical technology and services evolve. And we were interested in reactions, if this is helpful, and any thoughts that you might have.
Any comments, anybody? Jane.
So Pam, would I be correct in assuming that we're starting with the baseline of, for example, ACA preventive services, which have been adopted into state law in Washington just last session with the bill from Rep. Riccelli? Or are we modifying like the baseline that's current there?
I think what we're going to do is work from those benefit designs. So there'd be a PEP design, Medicaid, which of course has no cost sharing at all, and then a Cascade Silver plan, which has a blend of cost sharing. So those are the comparators we're thinking about.
So both PEP/SEB and the Cascade Care plans have to cover preventive services without cost sharing.
That's right.
So that's embedded in our baseline.
It is embedded.
Okay. And then I'm assuming the legislature has taken a number of actions in the past several years to cover services pre-deductible, right? Like advanced diagnostic imaging for breast imaging, insulin, et cetera, et cetera. Well, insulin's already considered preventive. Those would be in the Cascade Silver and generally in PEP/SEB as well. So again, it's sort of like, where's policy already been established? And the question is, where do we go beyond the policy that's been established?
Right.
And okay.
And as you're noting, some of those things are hardwired because they're already in state law. So that's what we'll find when we compare those packages. Vicki.
I saw Representative Schmidt had his hand up. Did you have a question or comment?
No, I was just curious. Do other systems that employ universal healthcare have a sliding scale on cost sharing?
Some do. You can find just about everything, but we did, and I can't name which systems there were, but we did find, I think in Germany, and there were others that had sliding scale. That was a common feature. Vicki.
I think my question was more about what we're going to ask Milliman for. Is it going to be the 3 plans and then for the groups that we know we want to cover, plus the self-insured, if they opt in, what that would look like? Because I think that might change the risk, right?
Yeah, that's a really good question, Vicki. So we look at the benefits design with cost sharing of those 3 packages. And then you can do the math to extrapolate the costs to the population that we're, planning to cover, that we know we can kind of get our arms around in the system. You bring up a really good question about self-funded that would opt in. I think that was your question. Am I right? Yeah. So that is a question we're actually in discussion with Milliman about right now, because it's complicated to think about that. And as any of us who've had experience with voluntary systems, there's often an incentive for kind of older, sicker workforces to be the ones that want to opt in. So I think Milliman is going to be getting back to us about how to think about that question. Honestly, I think their preference would be to leave them out for now and kind of work on what we can understand most clearly and sharply, and then come back to the opt-in question.
Because it could, like you said, it could mean higher costs Or if we get more people
Mhm.
in, it could be lower cost if we get the
Right. It's a seesaw because hope would be you would bring in younger and that you would also bring in the revenue to support the system. So that's obviously the preference.
Okay. And Jane, just put something in the chat box.
Yeah, so to help this, and Milliman actually did this study, Pam. We just in July put out a study on maternity care services cost sharing that evaluated the impact of 5 different scenarios, ranging from just eliminating cost sharing for prenatal care to eliminating cost sharing for all maternity care services. So hopefully that would be a helpful resource as
Yeah,
you're doing the work.
yeah, I haven't seen that. I would really like to look at it and share it with FTech.
Yep, I put the link into the chat.
Thanks.
Milliman did a really thorough job. It's a good report.
Okay, so any other questions for Pam and Mary? Or comments? And so I guess, do we need to make a vote on what the principles you're going to ask of cost sharing? Or are we good with what was, can we go back? I think it was a slide back that.
Yeah, so I think it's a little vague, but whether or not how you would adopt and what that would mean, whether these are just what you have in your back pocket as these, as the information develops to use or to modify as you see fit. These are just meant to be helpful in how you think about cost sharing. And I think it's, how formal you want to be in adoption is, I think, up to the commission. I don't know, Mary, if you want to add anything to that, but I think that was how we discussed it.
Nothing more from me, Pam. Thank you.
Jane.
I'm sorry to keep talking, but I have a stupid question. So
stupid questions, Jane.
So on slide of the what's going to be modeled, what Milliman is modeling, is one of the really nice things about the maternity care cost sharing report is that rather than just discussing existing cost sharing, Milliman modeled 5 different scenarios for how you could modify it and what the impact would be. So can we go back a couple of slides? If Milliman,
Audrey, could you go
keep
to the
going,
one that has the
keep going.
box, the blue box? There we
That
go.
one,
The
the other
box.
one, right?
Yeah.
I'm just trying to understand, is this one static modeling, or are we going to be asking, do we have the capacity to ask Milliman to, using the principles that the FTAC put forward, think about what kind of modifications there could be? And like, for example, one of the principles is you want cost sharing to be predictable, simple, transparent. To me, that's like co-pays versus co-insurance, because the least transparent cost sharing is co-insurance. So are we going to have the capacity to think about that or do that? Because that seems pretty important.
Okay, I'm going to wade in here. Yes, the answer is yes. But I think initially, what we will see about cost sharing will be pretty much what you're used to, especially for those of you on the commission who know these plans, these 3 really well. But then if the commission, I believe it's up to the commission to kind of think about next steps on cost sharing. Do we want everything to look like Medicaid cost sharing, which is there's none at all, or the cost of the plan is prohibitive enough that we want to think about some cost sharing, some consumer cost sharing. And that's where you can start to develop some creativity about how you think of, much the way you would describe the maternity. We're looking at 5 different scenarios. That's where the possibilities are to look at something that is, the transparency, the simplicity, things that we don't have in cost sharing right now.
And so maybe just real quick, this is a question for Mary, is do we have sufficient funding so that we can go back to Milliman and say, vary this, vary that?
At this moment, no, we do not. We have funding for the more straightforward, how do I say this? Apply the cost sharing that currently exists under these plans to this population.
Right.
Okay.
But
And I think what you're describing is later phases and potential phase 2 work where we could begin to, I think of it as turning knobs on cost sharing.
mhm.
Okay. I feel like we have been asked to be more formal about our decision making. So if you guys don't mind, can you go forward, I think 2 slides? Let's just make a vote about saying these are the principles of cost sharing that we're asking the FTAC to work on right now. Does that make sense? Or another motion if somebody else wants to make one? Are these the principles we want to look at as we move forward with understanding the costs?
I'm hearing Vicky call for a motion.
Or a discussion. I mean, do you guys want to make a vote? Just because I've heard over and over again that we need to be more clear when we're making a decision.
So, I mean, maybe one motion, and that's why I asked the question that I just asked about resources.
Mhm.
Maybe a motion is to, direct that Milliman proceed with what I think of as a baseline cost sharing analysis, since it's going to be based on current cost sharing methodologies, and then using the principles that the FTAC has put forward to us to try to identify resources so that we could consider how existing cost sharing models could be modified in a manner that are consistent with these principles.
Okay. Dr. Shima?
Yeah, I was just wondering if the first and the third kind of are conceptually related, right? So could we combine those? Because essentially what the saying is ensure that in the manner in which the cost sharing is pursued pays attention to income, right? So that it doesn't create cost barriers. So is there a way to better word where number 1 and 3 and really it's really the same concept that they're both exploring?
Reword 1 and 3 so that there's less barriers.
I kind of think they are talking about aspects of the same thing. So could they be combined into the same principle?
Okay. Any thoughts on that? And Nicole, don't go away. Okay, well, you're thinking about that, Nicole, go ahead.
Oh, sorry. I think they are pretty similar, 1 and 3, and I think they could be combined just to kind of like streamline a little bit. The thing that I was going to bring up, and I flagged in my head, didn't want to forget about it, but I think I heard Pam talk about number 4, considering adding in easily understood for individuals and providers.
I did add that in on my
Yeah,
notes.
yeah. So I think that just wanted to make sure not to forget about that piece as well.
Okay. So put 1 and 3 together as one item. And then on number 4, add that it's for, can you go to the next page, Aubrey? Create cost sharing structures that are simple, predictable, transparent, and easily understood for individuals and providers seeking care. Okay. Is everybody okay with that? So I feel like we probably have 2 things to vote on then. First, that chart of the 3 different plans that we're going to have evaluated for cost. and then second for using these principles going forward. As amended.
I mean, I would be happy to modify my motion to say that the reference to the principles is the principles as amended. But
Okay.
that the core point is that we don't just stop at what Milliman does,
Mhm.
that we try to find additional resources so we have the ability to, as Mary said, look at turning knobs.
Okay. Any other comments or thoughts? I think your motion put it all together. And if we're okay with that, that's fine.
Seconded, so I'll second that.
Okay. So the motion is that we're moving forward with the 3 types of coverage with Milliman to get to find out the cost of those 3 different plans, and then keeping these principles in place as amended and looking for more funds going forward to look at the different cost sharing options. Is that clear for everybody? Are there any questions? All right, all those in favor say aye. Aye.
Aye.
Aye.
Aye.
Aye.
Anyone opposed? Say no. Okay, Pam, is that clear enough?
Yes. It was very clear to me.
Okay.
I really appreciate the thoughtfulness about what we might want to do going forward, because it can get much more complicated. And then I really appreciate the amendments. It's really important that you make these your own. And I think those are really thoughtful changes. So thank you.
All right, thank you. Any other questions for Pam or Mary on the FTAC Financial Technical Advisory Committee? All right, thank you, Pam and Mary, for the update and the discussion. That was great. Please turn to tab 6. Yep, there we go. And for the annual report to the legislature, which was circulated with the packet last week, we'll vote to approve the report. But first, I want to open it up for discussion or comments. Any comments on the report? Edits, thoughts? I know we had a chance to review it and send edits. I know, Jane, you had some edits. So that's the whole report. Any comments, or I will entertain a motion. Does anyone have a motion about the report, moving it forward to the legislature?
Make a motion to move the report to the legislature.
Thank you, Nicole.
Second, I'm trying to give somebody else an opportunity to be first.
Thank you, Dave.
I just thought it would be weird to move or second a report to myself and Representative Schmidt.
Yeah, I realized that after I was just kind of silent.
All right, there is a motion and a second to approve this report to move it forward to the legislature. All those in favor say aye.
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 Any opposed, say no.
I'm going to vote in opposition. I think there's some unanswered questions. I know we're working on them, but there's a lot out there that has not been answered. And so that's the reason for my voting no at this time.
All right, thank you. Thanks for the clarification too. All right, the motion carries. And so we have a report to the legislature and obviously still some work to do. If we go to the next tab, we have agency report out. So just an opportunity for each of our commissioners from the different agencies to share out any work that might be connected to the work we're doing here. And Dr. Chima, I have you first. I don't know if you have anything to report.
Yeah, sure. Yeah, we know the DOH, Department of Health, just continues to work on a lot of issues related to healthcare access, particularly relating to the healthcare workforce. So, in the summer, we finished updates to the rulemaking process for the J1 visa program, which was intended to kind of improve equitable utilization of that program across the state. Particularly making it easier for rural communities to be able to access the J1 visa program. So that's been completed. There are other things in the pipeline as well. In January, the implementation of 1503, which relates to reporting of more detailed demographic information about healthcare workers in the state, so that we can also have better information on location of practice and things like that can help us understand distribution of healthcare workers and where we're having shortages. So that is in the pipeline to implementing that new law that will take effect from next year. So kind of a lot of other initiatives that are ongoing, a lot of them from the workforce perspective, but also other issues related to access. Nothing, I can't think of anything specific to cost, to coverage at this moment, but a lot of it applies to access. So and then obviously getting ready for legislation as well. So just continuing the normal business. Thank you.
Thank you. I got a note that Joan needs to go next. Is that right? Joan?
I'm certainly happy to go next. Can everybody hear me okay? I'm having some.
Yeah.
Oh, great. Hi, everyone. Let's see. So on behalf of the exchange, we're gearing up for open enrollment, which starts November 1st and runs through January 15th. So for individual market folks who purchase through the exchange, that's sort of what we are gearing our outreach and education towards at the moment. Probably of particular interest to this group, we've sort of finalized and certified the plan rates for plan year 2025. And we've also finalized our state subsidy amounts, both for people who receive federal subsidies and those who do not. So moving ahead with sharing that information broadly, we're working on the auto enrollment study that was direction provided from the legislature for us to look at what it would take to catch people as they're churning off of Medicaid and help facilitate them into a qualified health plan. We know that's an area where some people are falling off coverage and then we're not catching them. So we're taking a look at that. It's involved talking to some state colleagues in other sort of across the country who are doing auto enrollment work and facilitated enrollment work. It's also involved looking at some data from the year of the Medicaid unwinding to look at who we caught and who we were able to sort of provide coverage for. So I'll share that report in the chat for staff. And then we're also working on year 2 of our immigrant outreach campaign. And this year that newly involves reaching out to, there are certain people with a certain immigration statuses, including Deferred Action for Childhood Arrivals or DACA recipients have new access to federal subsidies due to a recent decision. So our outreach has involved making sure we reach out to those communities as well so they can take advantage of federal savings. I think that's it for me, and happy to answer questions if anybody has them.
Thank you. Any questions for Joan?
Thanks, Vicki.
All right, thank you. Dave, are you ready?
Sure. I won't steal Becky Carroll's thunder as she is on the agenda to talk about some of the work that people, the commissioners and the public would be interested about maybe see it from that angle. But I'll just put a pin in that for a moment because Becky will be here to present about the about that work, the Apple Health expansion for I think that's our next agenda item. Similar to Joan, the PEB and SEB program gearing up for open enrollment. Different dates, just like everybody's. This PEB and SEB is October 28th through November 25th. The best way to remember it is open enrollment ends the Monday before Thanksgiving, so it'll be done before Thanksgiving. We have a lot of work that goes into preparing for legislative sessions, so just highlighting that the agency submitted over 50 decision packages that are considered policy ideas. We have 6 potential agency request legislation topics that are working their way through the process after our late summer stakeholdering. And that includes the conversation around what we're calling the PEB/SEB affordability bill idea to address provider contracting rate, provider contracting terms for the PEB and SEB program plans. We also have over 40 legislative reports are gearing up for submission to the legislature in the months of November and December. And that doesn't include the one that this group just approved because they're tracked on a kind of separate thing based on the authority of the boards and consolidation. So there's even more than 40 that the agency is working on in its finalization. I do highlight among those 40 is the PEB/SEB consolidation report, because that's a topic that the commission has talked about is a potential transitional step that could be incremental step that could be done. And so that report's due December 1st. We did some stakeholdering on that in July and August. And again, we're gearing up for that early December submission on the topic of mechanisms for or options for how to consolidate certain aspects of the program that were requested in a budget provision. And then another topic that has some interagency work. I don't know if this is going to be on your list, Jane, or not for OIC, but HCA and obviously OIC participated recently in some conversations with Senator Cleveland and other stakeholders about network terminations and provider contracting. And so I think many people are familiar with the large network termination notices that have been going out in the past year or two in a lot of different instances that have a profound impact on consumers who often don't experience those in the way that many on the payer and insurance side have experienced them in the past. There's a lot more consumer impacts on those. And so Senator Cleveland has asked for some work and brainstorming in that area. And so there's some work that I just think is kind of a little bit tangentially related, but I think helpful for people to know is great. So that's some of the things I was going to highlight.
Thank you, Dave. Any questions for Dave? And so on the rates for PEB and SEB, those are reference based, is that right? Or is that just
yeah, the if you're talking about the affordability agency request legislation topic that's being stakeholdered and discussed fairly with the Dow, yeah, it's a reference based pricing. That's it.
Yeah, I think that's something we should really be paying attention to as far as, when we're thinking about reimbursements. Because I think it's interesting to hear from the providers and the insurance carriers and figuring out where's that line, I think one thing where we really want to make sure is that the providers are getting paid the cost to provide care at a minimum. All right, thanks, Dave. How about Joan? Do you have some things to share with us? I think you have your affordability report later, so I don't know if you had anything else.
Right. So essentially, we've been busy implementing legislation. We're doing rulemaking now on prior authorization bill, on the healthcare benefit manager bill that passed last session, and on ground ambulance balance billing that passed last session. So ground ambulance balance billing prohibition is effective January 1, 2025. We're aware on prior auth that the Association of Washington Health Plans is talking to legislators about legislation to try to align a bit more with federal law on prior auth timelines for putting into place API systems. We did the affordability report, the maternity care services report. We're working with DSHS on Reparcelli, your provisos related to coverage of essential workers and nursing home workers. So that work's going on. We have the contractor identified for that. We've started our project from the legislature to try to come up with the cost of what adding palliative care services to fully insured health plans would be. Probably the newest thing to report is that last week we received about a $600,000 grant from the federal government to focus in on access to reproductive health services, and especially over-the-counter services that health plans have to cover. So contraceptives, breast pumps, prenatal vitamins, all with an eye toward making sure that people are able to access the benefits that the legislature has already said must be covered. So we'll be doing some compliance work to make sure the insurers are appropriately implementing that. We'll be doing some big public education work, and we'll be taking a look at how we can simplify the process so that when a woman wants to buy contraceptives, over-the-counter contraceptives, she can either take it to the pharmacist and have the pharmacist be able to process the claim with no cost to her, or there's an easy way for her to get reimbursed by the health plan. So we're really looking forward. We're actually already starting the administrative simplification component of the work. So those are the big things.
Thank you. Any questions for Joan? And is Omar not here? I think I remember that from earlier. Okay. Any other commissioners have any updates that are relevant? Representative Riccelli?
I just wanted to express gratitude for the healthcare committee work session for folks who presented here, and also I thought we had some good public testimony. So I just wanted, and if folks are interested, they can go back and watch that work session, which I think was actually pretty interesting broadly on network advocacy and other things as well. But just expressing appreciation and just another opportunity to try and get the work that's being done out in front of broader public, and as well as additionally legislators who aren't serving on the commission.
Thank you. And I think if you didn't get to witness the session, there was a lot of great discussion before our presentation too that really supported the work that you were all doing here too. So that was really great, all the different topics. Yes.
Yeah, I'll use that opportunity just to say one more thing in front of the commission, to say that one thing that I've heard continuously, and I know Rep Schmick has shared it too, is this work is really important. Also, we're hearing a lot about folks having access, maybe even to insurance, even if the deductibles are high, etc. But it's becoming front and center. The access to care is what's top of mind, and there's a real lack of access to care for people in rural and underserved areas, but across Washington. So I think that was very relevant, and that statement continues to come up.
Thank you. Anyone else? Okay, thanks for those updates. I appreciate the work you guys are doing at the agencies too. And there's so many things going on, it's almost impossible to track, so I appreciate that. So now we're going to move on to the Apple Health Expansion update from Becky Carroll at the Healthcare Authority. Becky was here in August, and she's back to provide an update on the information she shared at the previous meeting. Becky?
Good afternoon, everyone. Thank you again for some time on your calendar or in the committee agenda to talk about Apple Health Expansion. Happy to come back and provide a little bit more information and just to kind of ground folks in the conversation if we want to move forward to the next slide. A little bit of background here. I think you're all aware that Apple Health Expansion is joining sort of a suite of programs that HCA has implemented to provide services to individuals who are not qualified for federally subsidized coverage because of their immigration status. So we continue to have medical care service, our emergency medical or AEM program, Apple Health for pregnant individuals, after pregnancy care, Apple Health for kids, and then of course the new Apple Health Expansion. Move to the next slide. So this work has started back in 2022 in pretty deep coordination with our Health Benefit Exchange and DSHS partners. We have been working on implementing, bringing up this new program since 2022 when we were directed by the legislature to start exploring what it would take to operationalize a Medicaid lookalike program for individuals who don't have proper documentation to have a federally funded Medicaid program access. In 23, we received that order to implement on the 1st of July. We did have a limited pool of funding available that was expanded in 24. I think always with recognition that the program funding was not at the level that the agency requested, and that we all, I think, in the state, right, really recognize that there are definitely more individuals who would be eligible for Apple Health Expansion than we have spots available. We move to the next slide. Eligibility for this program really mirrors Apple Health, Medicaid, our federally subsidized Medicaid programs in large part, right? These are individuals who are over the age of 19, have accountable income under 138% of the federal poverty level. They're not currently qualified for another Apple Health program based on their immigration status. These are also individuals who are not pregnant or did not have a pregnancy end in the last 12 months. Those individuals would be eligible for Apple Health for pregnant individuals or after pregnancy care coverage. And then they're also not eligible for federal advanced premium tax credits through the individual market or federally funded medical assistance programs. So without Apple Health Expansion, not a lot of coverage options other than purchasing off of the exchange under the new 1332 waiver programs. I'm going to move to the next slide. So we went live on June 20th, again, in close collaboration with DSHS and Health Benefit Exchange. We quickly met our enrollment cap. On the 21st of June, we stopped or closed enrollment for those who are 19 to 64. And on July 3rd, we closed enrollment for those who were 65 and over. To the next slide. In total, we've enrolled 12,161 individuals into the program. We have coverage in 34 of the 39 counties across the state. And I think another great piece to sort of keep in mind here is that we have language assistance requested in 35 different languages. So we do feel like in this initial enrollment, we did get statewide access to this new program. And we covered as many of the immigrant populations and communities that we could, for sure. We hit that total enrollment. We still are encouraging folks to come in and put their information into Health Plan Finder, apply for coverage, and if they are at all eligible for any of the other Apple Health programs that we mentioned at the top of the presentation, we get them into that kind of coverage. Otherwise, they receive a denial for Apple Health expansion. That denial allows them the opportunity to be part of our enrollment management policy. So we have about 8,292 individuals who we have issued a denial into the program since go live. That number is as of September 20th, constantly changing, but to kind of give you a sense of where we're at. And so should we as an agency find that we have additional dollars and can enroll in more individuals, we will use our enrollment management policy, which we worked with community to develop, and sort of do a random selection of folks who've received a denial letter due to the cap. So as we move forward, and I think on the next slide here, talk a little bit about the decision package that the agency submitted. We are seeking to increase funding of $84 billion over the next couple of years. We're really proposing increasing available slots of the program by up to 14,000 individuals, bringing enrollment to 26,000 by 2027. The decision package poses adding 4,000 folks July 1st of 25, 10,000 July 1st of 26 to kind of make up these numbers. It includes the agency administrative costs that are associated with that, and it includes continued funding for our Community Engagement Advisory Committee to reimburse those lived experience community members who are enrolled in the program or who are advocating for the program to participate in this Community Engagement Committee. We've been working very closely with them for the last couple of years now, in coordination with Health Benefit Exchange and DSHS to really get feedback on the coverage Apple Health Expansion Program itself, letters, ways to look at language access and interpreter services in new and really client-centered ways. So feel really passionate about that ask. We are also requesting additional dollars to develop an IT-based waitlist solution with the idea that that would replace that enrollment management policy, that random kind of random selection of folks who've been denied into the program, provide an orderly wait list based on application date and all the relevant factors. And then really wanting to support funding for additional outreach activities for Apple Health expansion. We see a lot of need to find creative ways to reach community in collaboration with community-based organizations and trusted members in trusted representatives in immigrant communities to really get the word out in a multitude of ways. So did ask for some additional dollars there. So that gives you sort of an overview of where we've been, where we're at currently, and where we hope to go. And I know the committee is looking to talk about this a little bit more, but I'll open it up if you have any questions for me. Anything I didn't cover that you're looking to cover?
Nicole.
I've missed this, but this includes like any additional FTEs?
Correct.
Anyone else?
Put a fine point on it. The decision packages it could be that the agency forward so always reminding.
You're kind of breaking up, Dave.
Oh,
sorry. Guess what you said.
It's working better.
Yes, there you go.
I'm just putting the microphone in front of my mouth. Just saying to put a fine point on it, this is an example of one of the roughly 50 decision packages put forward by the agency. It's just always, I think, important to remind people of the breadth and scope and context of everything that the healthcare authority does. But it's an important one from the agency leadership. Sure.
Thank you.
So, Vicki, Dave, question for you. What's the timing on, and maybe Becky, you might know this too. What's the timing on the report related to low-income Medicare beneficiaries and whether we can bring more folks into dual coverage? Because I think I saw in Healthcare for All's comments a reference to, I think it might be RDA doing the report over at DSHS.
I am familiar a bit with that report, Jane. This is Becky. I do not know the timing of that. I can ask our team that works with dual eligible folks.
Okay, thanks.
I also don't know the.
Okay. Anything else? Thank you, Becky, for coming back and providing the update. We have the opportunity to discuss potential recommendations to continue support of the Apple Health Expansion Program, including recommending additional funding for this program. Is there any discussion on this proposed recommendation or any?
I guess the reason that I asked the question that I did about the Medicare folks, and also Joan, does HBD still have the $75 million price tag to sort of fully fill out the state subsidy program, especially if the ARPA subsidies go away?
Yep, Jane, that's right. We're looking to continue and slightly increase the state subsidy amounts.
So I'm trying to, Vicki, sort of loop back
Mm-hmm.
to the recommendations that we had that were in the final report. It was on, it might have been a graphic that Liz showed earlier. And I'm just thinking about, well, God only knows this program is needed. There are, and we've heard Rep. Riccelli and many others talk about what a tough budget situation there's going to be. Are we thinking about this in the context of those other programs as well, or this in isolation? I'm just curious.
I think Representative Riccelli has a response.
No, I mean, I'm very likely to abstain from this vote, not because I don't support expansion, but with competing priorities, my job is not just to move forward the commission, but look at the big picture. So I'll be abstaining if we move to a vote.
Okay. And I'm here at the Washington State Public Health Association conference where both Senator Robinson and Speaker Jenkins talked about not being hopeful for asking for money this year. I mean, Representative Schmidt.
I would only point out or like to say that if we're going to ask for more money, I would think it needs to go for Medicaid reimbursement to help pay for those people trying to get current services rather than continue to expand. Mm-hmm. And I think Marcus is probably, I mean, Rep. Riccelli's probably right, probably should abstain from this vote.
Thank you. Any other members have thoughts about this motion, edits? Is there a motion?
I think, Chair Vicki, I would like to say looking back at the prioritization, I've highlighted twice now in this meeting that the Healthcare Authority had roughly 50 decision packages that were submitted from a policy perspective. And I believe that this was the second highest rank in our prioritization as a leadership team put forth in that decision package prioritization process. So from that standpoint, I think it would be at least appropriate for me on behalf of the agency to make the motion and see where the commission lands on it. So I will make that motion.
All right, thank you, Dave. Is there a second?
Vicky, happy to second it from the exchange. We just see a continued need, and we're hearing from applicants who both have life-changing gratitude when they get onto this program or call our call center and are pleased to find out they're eligible. And we are hearing the flip side of that now, people calling who are unable to sign up and wanting to know everything they need to do to get in. So from the agency perspective, happy to second it.
All right. Representative Riccelli?
Just for discussion, it's been moved and seconded. Okay.
Yeah, we're at discussion.
I just want to clarify, I'm interested in seeing the expansion here too. I'm also interested in seeing all kids get universal meals and a whole bunch of other competing things. So I just want to be very clear about how supportive I am of making sure that folks have access to healthcare and don't end up in the emergency rooms, and how we're looking at covering all folks in our state, but also just trying to be very mindful of broader responsibilities, and that's why I'll be abstaining.
All right, thank you. Any other discussion? All right, all those in favor say aye. Aye.
Aye.
Aye.
Aye.
Opposed? And we have 2 abstentions.
Yeah, I mean, Vicky, on the motion, I'm sort of with Rep Riccelli. First of all, we're going to have a new commissioner. I don't know where the new commissioner's priorities are going to be, but understanding that this recommendation is made in the context of issues like, right, the expiration of ARPA without additional state subsidy funding could mean 50,000 people lose their just can't afford coverage anymore.
Right.
And so no matter where you're sitting, there are decisions that have really, really big consequences for literally tens of thousands of people. And so the only thing that I would say is whether we can sort of say something about the fact that this motion is supported in the context of understanding, any number of additional needs, such as affordability for the exchange, right? Low-income seniors' ability to afford care. It's just, it's hard for me to look at this in isolation, knowing everything else that's going on.
Yeah. If we don't have everything on the table, yeah, and I guess we're just saying we're supporting the program and recommending additional funds. I mean, do we need to add anything, Nicole?
I say I'm in an agreement with folks on this one. I know that there's a lot of competing priorities this upcoming session, and I don't think there's any harm in making a recommendation, because that's all it is at the end of the day. Recommending support, whether or not the legislature chooses to use this as one of their priorities is a whole other matter that would be up in their hands.
Maybe we take a roll call vote then. Would that be more comfortable for people? I just saw 2 hands go, and then, okay, Dave.
Yeah, I was going to say, I know I casually said I make the motion that's on the screen, but I do want to really know that this motion doesn't do. It doesn't say supports the Healthcare Authority's decision package for $84 billion. It doesn't go into the specificity, I was purposefully didn't want to add those extra types of words in because it doesn't. I highlighted my comfort in bringing forward as a agency's seat on the commission because it ranks so highly in our leadership team, and I wanted to highlight, like, in the context of all the things just within the healthcare authority, which is a substantial portion of the state operating budget. Like, we have prioritized this expansion as a very important thing. So I just wanted to highlight that this isn't supporting the healthcare authority TP, but it is similar concepts to that, and that's why I felt so comfortable with it. So, I'm kind of like echoing what Nicole says as, it's recommending this concept, and, we're here just from a healthcare perspective, all of us. There's plenty of other aspects of the operating budget that could also be competing for a finite amount of funds. So I really appreciated Nicole's context and just wanted to put a fine point that this does not say supports the decision package from the healthcare authority, but it's the concept that it's there in the prioritization that HCA itself has.
Thank you. Joan?
Oh, thanks. I just similarly wanted to share that people who are assisted by the Apple Health expansion, now that the cap has been hit, those same people can then come to Health Plan Finder, and to the extent there isn't a broader affordability barrier, can purchase care that is subsidized by the state subsidy that I think Jane highlighted. So I think we do see it as sort of two sides of the same coin at the exchange as well, to the extent that the Apple Health expansion is sort of maximized to help people in need, that those Cascade Care savings dollars can get distributed sort of in a broader way on the marketplace side. And then to the extent that the Apple Health expansion program constricts, there's more demand on the state subsidy on our side. So we see them as sort of working together there, and appreciate people raising both the Cascade Care savings subsidy side and the Apple Health expansion side as funding that helps support similar populations.
Thank you.
I mean, Vicki, I think, we already had the vote, and the vote was pro on this. So maybe one way to do it is to have the minutes reflect sort of the contextual discussion that we had around this,
Yeah, thanks, Jane.
so that people won't assume that we looked at this in isolation.
Yes. Joan, did you have something to add?
No, just delays on my end. So thought I put the hand down, then tried to take it down again and put it up.
Okay, so we'll make sure that the comments are noted in the minutes. Representative Riccelli?
Yeah, and I want to appreciate a lot of what we're discussing is what legislators struggle with quite a bit. I do think by adding the recommending additional funding, it is lifting it up, and I think that that's okay. But I think by doing it, it's not. We are saying, amongst other things, this is something being prioritized, and that's okay. And I think that that's being discussed here. So just a little comment, like, this is a lot of what folks battle with, and probably a good primer to at least what is being stage is being set for January, because as a reminder, maintenance level is being predicted at in the 4-year outlook is at least $3 billion in the red, and and then there's other factors that are coming November that could impact a lot of things as well. So and this is why actually we should just make healthcare more affordable and bend the cost curve the right way.
Yeah, making our point for us. All right, so we have two. I'm just gonna say we're done with this. All right. I think we all kind of agree on the same principles. We have two more topics. I think we have Jane's the affordability report from the OIC, and then the prior authorization. discussion. And so do you guys want to take your 5-minute break now and then come back for Jane's presentation? Do it now. So come back at 3:46 and then we'll have Jane give her presentation. Thank you. Okay, don't know if my clock is off, but I have 3:46. People coming back. Hi, Dave. There we go. Thank you. I think we need Jane. All right, Jane, are you there? There she is.
I'm here.
All right, turning it over to you.
Thank you. So I know we're already behind, and I don't want to cut off the discussion about prior auth. So this is going to be a speed dating version of the affordability report. So let's go to the next slide. And just super, super quickly, legislative direction was for OIC to basically try to answer the question. There's been a lot of discussion about different affordability options in Washington State. Let's do the analytic work and the actuarial work and look at what the impact would be in Washington State if several different options for affordability were under consideration. So next slide. And you can pass that one. And you can pass that one. And the preliminary report, as everybody probably remembers, a lot of discussion about horizontal consolidation and vertical integration in the healthcare system, as well as discussion about significant entrance of private equity investors into the world of healthcare in Washington State, and also significant vertical integration among and our insurance companies who own PBMs, who own healthcare practices, who own a lot of other things, and who administer a whole bunch of self-funded group health plans. So we can click through the next 3 slides. And next slide. And next slide. And this is, okay, now we're getting into the meat of it. And I do want to, especially with Liz and Gary Cohn here, I do want to acknowledge the remarkable work that HMA did on this report, as well as Wakely on the actuarial work. So when in the preliminary report, we had about 8 or 9 different policy options that were discussed at a very high level. And the agency needed to decide which 5 to focus in on the most. And we had discussions with state legislators, with the governor's office, with the OFM, with the healthcare authority, with the health benefit exchange, with health insurers, with hospitals, with other providers, with consumers, and landed on these 5 options largely because they impact different aspects of the system. Some impact health insurers, some more heavily impact healthcare providers, some get at price of services, others don't get at direct price of services. And then whether there were different markets that were affected, some that affected largely the individual markets, some that could have much broader impact. So that was sort of how we reviewed it. And what you're going to see is for each of the options that we go through, I'm going to talk just for a minute about what it is. I'm just going to show you super high-end results of the actuarial work. And we also took a look at, and beyond just the impact on premium, what additional impact might we see in Washington State if the policy were implemented? So let's go to the next slide. Next slide. Next slide. Like I said, this is speed dating. Some of you remember that back in 2018, Commissioner Kreidler proposed a reinsurance program in Washington State. And the bill came pretty close to passing, but the issue that held it up was how to fund the state portion of the program. And essentially, reinsurance says, I'm going to take a chunk of the highest cost claims out of the individual and or small group market. And I'm going to figure out a different way to pay for those. And then because the federal government is going to be paying less for premiums, 17 states now have reinsurance programs and through federal waivers get federal funding to help fund a portion of the cost of the program. So next slide. What we did was we modeled for 25 and 26 what would happen if we structured a reinsurance program so that we could reduce premiums by 10%. And you can see where we landed. It would have not a super big impact on enrollment in this is the individual market in individual health plans. So in the neighborhood of 4,000 to 5,000 more people would come in because premiums were more affordable. And probably the most important thing to point at is what funding would be needed to actually pay those claims that we would be pulling out of the system. So, and I know Joan has been talking a lot about this in the health benefit exchange. There were the ARPA subsidies, the additional subsidies, premium subsidies that were enacted during COVID, expire at the end of 2025. And so the cost of doing a program like this is significantly higher if those ARPA subsidies go away. So bottom line, you can see if the ARPA subsidies in place, we would get about $134 million to help finance the program with 42 million state share. And if those ARPA subsidies go away, that federal subsidy goes down, so the state cost goes up. Next slide, please. And anybody can interrupt me at any point with questions. Please feel free to do that. I'm from New York. I'm used to being interrupted. So the other thing that we did is we looked at what would happen if you did reinsurance in the small group market. And what you see on this image is what would happen over a 5-year period, so 25 to 29. And again, you can see that the premium savings, the impact on premiums for individuals, somewhere between $750 and $1,000 a year. And there would be some significant savings for consumers. But what really hits you for the small group market is that the state funding that you would need to do this in the small group market is pretty hefty because we don't have access to those federal pass-through dollars. So this is sort of reinsurance and how we look at it. So yes, it works. It's been done by other states. You can reduce premiums, marginal impact on enrollment, but significant investment of state dollars. Next slide, please. And then we looked at, and again, you'll see a slide like this for each of the options. And what would happen over that 5-year period in terms of the impact on the economy overall because premiums are lower. So we would see increased employment because employers are spending less on premiums. We would see the opportunity for folks to shift from part-time to full-time, and then people would have out-of-pocket savings. But of course, we have to offset against that Social Security and Medicare and federal income taxes that would be paid. And so you could see over a 5-year period, the net impact, because again, people would have more money in their pocket. So we'd also see things like household spending increase. We'd see a net savings to the economy of about $2.4 billion. Next slide, please. And I sort of talked about the reinsurance pros and cons, advantages. It's been done. It works. It mostly helps people who are not having access to subsidies to get coverage. So it's mostly helping sort of the middle to middle upper income folks that are getting coverage either through the exchange or through a small employer plan, but it does definitely require significant state funding. Next slide. Next slide. The second option that we looked at was increasing the medical loss ratio standard. Under federal law, the Affordable Care Act said to health insurers, okay, we're going to cap the amount that you can, the percentage of premium that you collect that you can spend on administration. And so this option would affect the fully insured market, individual, small group, large group plans. Next slide, please. And current law says that for individual and small group health plans, a health insurer has to spend at least 80% of the premium that they collect from you on the healthcare care services that the enrollees are getting and quality improvement activities. And for large group health plans, that threshold is 85%. Over the years, there have been a number of discussions about whether we should increase that minimum MLR standard to 88%. And interestingly enough, what we found, we asked Wakely to go back and look at what insurers' actual minimum medical loss ratios were for 2019, 2020, and 2021. And most of them, with the exception of coordinated care, whose MLR was pretty low, were getting pretty close to that 85 to 88% standard. Next slide. So really, when you look at it, what it means is that the impact on premiums for consumers, you could see this is over a 5-year period, right? It would bring down premiums a bit, either that or insurers would be paying out more rebates to their enrollees. But the aggregate savings in the individual market, 37 million to 45 million, small group even smaller than that, and fully insured group 36 million to 50 million. And the reason that the aggregate savings and the impact on premiums aren't that great is because so many of the health insurers are already at or near that 88% threshold. So next slide, and next slide. And I think I pretty much went over the advantages and disadvantages. I think I think Massachusetts has a minimum MLR of 88%, but very few other states have pursued this option, largely, as I indicated, because the actual experience of the health plans is pretty close to that standard anyway. Next slide. Reference-based pricing. This is probably one that we spent, next slide please, that we spent most of our time on. Reference-based pricing, and David referenced the fact that the Healthcare Authority has been stakeholdering a proposal that would set reference-based pricing for PEB and SEB. If you regulate how much a health plan can pay for a service, if you cap that amount, then you're impacting PEB, SEB potentially, and all of the fully insured health plans. If you set rates on how much a healthcare provider can charge for a service, then you're also bringing in the 2 to 2.5 million people that get their coverage through self-funded group health plans. Next slide. Can we get the next? Okay. So essentially, reference-based pricing establishes standard reimbursement rates for a chosen set of health services. And it's tied to a defined pricing level most often. Yes, Rep Schmidt.
Will this go across everywhere, like critical access hospitals as well as the larger hospital systems?
This can be designed however you want it. The way it's modeled right now, the way we had it modeled, it included critical access and sole community hospitals, but you could easily carve those facilities out of the program because the number of folks that they care for is so small that carving them out and protecting them wouldn't substantially impact the overall savings that you would achieve from the program.
So I was under the impression that we already had, or we use there was a standard set of prices that we paid for a procedure. Like if a person gets a knee done, they go to the preferred hospital and they get a flat rate. But that precluded critical access hospitals because there was only certain hospitals where you could go to have that procedure done.
Are you thinking about commercial health plans generally or PEB and SEB?
I don't know. I know enough to be dangerous and so not enough to be accurate.
Uh-huh.
But I'm just, because I remember this and I forget the acronym, but there was a flat payment that was being paid.
Oh, was it episodes of care?
Well, it could be. I thought it was for Medicaid.
That
Like,
excellence is that?
Pardon me, Dave?
Centers of excellence.
Yeah, I think that was because we've paid a standard fee for that procedure. And then that's and you had to go to the certain places to get that done. Is that accurate?
So I think you're describing, especially the PEB and SEB programs, that is what us, and it's modeled off of other employers in the country that do this, is there's a preferred setting. At least the way we do it in PEB and SEB is we have preferred facilities where if you go to those specific facilities, you have no cost share. So your carrot to go to the preferred facility is no out-of-pocket costs. You can still go to other providers, but you will then have a cost share. So we're incentivizing and motivating and trying to steer people to certain facilities who have, for example, lower complication or readmission rates, things of that sort, and they have such high quality outcomes that the plan picks up the full cost of it, and it's kind of a bundled flat payment. So that is something that's in PEB and SEB. It exists in various parts of the market, but it's not universal.
Right.
Okay. Thank you for that clarification. So then I can ask my question now intelligently. So what's the difference between what you're proposing here and what they're already doing in PEB and SEB?
With PEB and SEB, centers of excellence are limited to a small number of different types of procedures, right? So it might be bariatric surgery, it might be knee surgery, knee replacement, it might be hip replacement. Here, depending upon the breadth of what you design, and you'll see when I pull up a slide later, you could be applying it to all hospital inpatient services, all hospital outpatient services, all physician services. It's just a matter of how you design it. So it's greater breadth of the services that would be impacted. Okay. So Oregon has actually used and implemented reference-based pricing for their state employee and school employee programs. And there have been a number of recent articles, including one in a recent edition of Health Affairs, that have shown that they have realized significant savings and they have not seen hospitals just dropping out of the program. And it also shows savings when it was used in Montana. We have a mini version of reference-based pricing in Washington State, and that's the public option plan. But there, the 160% of Medicare standard is an aggregate standard. And so there's significant opportunity for there to be variability in reimbursement rates as between different types of providers, as long as the insurer lands at an aggregate standard of 160%. To date, we have seen lower premium increases for public option plans than for other plans on the exchange. Next slide. So we asked Wakely to go into the 2022 all payer claims database and say, okay, and this is just a subset of what we looked at. We actually looked at about 15 different services and say, if we took what was spent on those services and we repriced them to Medicare in 2022, what were we paying in the commercial market on average for those services? And you can see it ranges from almost 310% of Medicare for hospital emergency room visits, down to less than Medicare, 88% of Medicare, for mental health and substance use disorder professional fees. And we see about primary care, almost 150% of Medicare, which actually is a good thing. That's the direction we've wanted things to go, because we want to invest more in primary care. And then you can see hospital outpatient surgery, 232% of Medicare, inpatient surgery, 200. And what this points to, we think, is reference-based pricing can be used to just spend less, but it can also be used to spend differently. So, for example, we asked Wakely to run reference-based pricing at everybody at 160% of Medicare for all services. And for 2022, it would have yielded $450 million in savings, but that is with spending $200 million more for mental health and SUD professional services. So it's an opportunity to think differently and really direct where you want to invest funding for commercial health plans. Next slide, please. And the cost savings, remember I said, Rep. Schmick, you could decide that you want to carve out critical access hospitals. You can think broadly or narrowly about how you want to approach it. So the cost savings are really going to be impacted by how the program is designed. But based upon experience with other programs, we know that the more affordable premiums are, right, the higher the enrollment in healthcare coverage is. And again, as I indicated with this, you could impact up to the entire commercial market if you cap what providers and facilities can charge rather than regulating what insurers can pay. Next slide. And here we looked again at what if we said in 2027, everybody was at 160% of poverty, or 160% of Medicare, what kind of savings would that get to the state? And here, on average, the annual savings to the state every single year, in addition to what you would save on healthcare costs, would be about $320 million, as well as generating about $25 million a year in additional tax revenue. Next slide. And I think, we sort of talked about the advantages and disadvantages. Clearly, this would be more complex to administer, and it could cause disruption in the healthcare system, but it gets directly at price, and it can be used, as I indicated, to incentivize investments in services where you want to redistribute healthcare spending. Rep. Schmick.
Could you talk about the significant disruption in healthcare delivery, and just to tease that out a bit more, please?
So I think to tease it out, it all depends upon, for example, if you were to say, I'm going from status quo to 160%, that's a really big change. If you were to design a reference-based pricing system where you ramp down over time, so you started at 200% of Medicare, and then you went to 190, and then you went to 180, it gives the system time to sort of adapt to the different incentives and the different payment levels that they would get. And it could cause, and just as you were raising, if you went to 160% of Medicare for critical access hospitals and they just couldn't survive on that, then, right, you could potentially be putting those hospitals at risk. So those are the kinds, so it's all a matter of how it's designed, what it's applied to. Next slide, please. And really quickly, we did model hospital global budgeting that was explicitly directed in the proviso. Next slide. And if you do hospital global budgeting, it would involve getting a waiver from the federal government for Medicare, Medicaid. Maryland is the only state that has done this to date. Next slide. And what we did with this one is essentially say what would happen if every hospital had a global budget that they needed to live within. And they would provide all of the services to all of the people that they were serving within that global budget. And the idea is to incentivize hospitals to shift away from strategies that are geared toward increasing revenue by increasing the volume of services that they provide, and instead think about things that can increase efficiency. And as I indicated, only Maryland has implemented a model like this. Next slide. And what we did with this model is basically say we would not apply this to critical access, psychiatric, rehab, or children's hospitals when we did the modeling. And we basically said, what would happen if you set hospital global budgets to grow at the rate that the Healthcare Cost Transparency Board has set? Next slide, please. And here's what we came up with. It would, depending upon how implementation went, you could see a 0 to about 7.1% reduction in hospital costs. And again, right, higher enrollment because of greater affordability. Next slide. And in terms of economic impact here, because you would be affecting the entire healthcare system. When you have those savings, it results in much, much bigger overall positive economic impacts to the state. So $6 billion over a 5-year period. Next slide. And here again, advantages, large effect, incentivizing investments in high value services, very complex, requires a federal waiver. And to date, the only state that's fully carried this off is Maryland. Next slide. And so then we just wanted to look really, really quickly at what would happen if current healthcare spending grew at the rate that was set by the Healthcare Cost Transparency Board. Next slide. And again, we were saying, what if everything grew at that rate rather than exceeding that rate? Next slide. And here, and we can go to the next slide. And here, basically, we said, we looked at CMS's projections for growth in healthcare spending. And you can see if those benchmarks were met, that you would see between $1 and $2 billion a year in healthcare savings in the state. So over a 5-year period, $8.4 billion in savings. And that's what would happen if you literally just said healthcare is going to grow at the benchmarks that were set by the board. Next slide. So it does help to provide some context. Next slide. And again, there, given the amount of savings that you would see over a 5-year period, the net additional economic benefit of slowing healthcare costs to that rate is a value of $10 billion to the state of Washington. Next slide. And I think we talked about here, I mean, advantages, greatest impact on healthcare costs in the state. It's a flexible approach because the system would be deciding how it was going to adapt to it. But as we've seen here and as we've seen in other states, the healthcare cost growths are pretty much exceeding the benchmarks that are being set by state. Next slide. So I think that pretty much finishes it up. As I indicated, really what this report was about was giving the legislature the information to understand what would happen if one were to implement this policy in Washington state. So we are hoping that it will be of great value to the legislature. That's it. I'm happy to take any questions. I know there was a lot there. That was a 150-page report in, what did I do it in? 20 minutes.
20 minutes. Any questions? And the link to the report should be in the package.
Yep, it's on this last slide.
That's a lot to think about. All right.
Thanks.
Thank you, Jane. So we're okay with moving on? We've got a couple things to get through and 45 minutes. Right, if you go to tab 10, we're gonna continue our conversation on administrative simplification, or admin simp. Specifically the one on prior authorization. So I'm going to hand it over to Liz Argent and Gary Cohn.
Thank you, Chair Lowe. I'm going to take the first part of this. So we can go to the next slide, please, Audrey. So in the discussion about prior authorization, you'll recall that you had a presentation at your August meeting from Michelle Long at KFF, and she went through what the federal government, a number of states have done, and what Washington has done with respect to prior authorization, and two possible policies that Washington has not adopted, but a few states have, were raised as for possible consideration: gold carding and standardized forms. I'm going to go through the pros and cons and some discussion of each of those. In preparation for the meeting and in conversations with Chair Lowe and HCA staff, it occurred to us to raise another issue, which is that one of the parts of Ms. Long's presentation was some data from the OIC's prior authorization report from last year. And what it showed was that for many of medical services, the approval rates in Washington are very high. And so that led us to think about a third approach, which I'll talk about after we go through the goal carding and standardized forms. So next slide, please. So goal carding aims to reduce the volume of prior authorization requests by essentially identifying those providers who have a high percentage of approvals. And if they can show that and the states that have done this look at 90%, 95% over a 2-year period, they vary a little bit. But if they reach that threshold, then they're exempted from having to seek prior approval for the particular services that they are able to achieve that level of approval for. Next slide, please. So pros, obviously, it's a reduction of administrative burden, both for providers and for the insurers. It can possibly increase access for patients to the extent that services that would have been denied are approved, and therefore may improve efficiency and health outcomes. I think the cons all relate to the difficulty. If you're going provider by provider by provider, that's pretty complex and burdensome in and of itself. And the process for getting approval may be, not that smooth. And what I would say is that I look to see whether any of the states that have adopted this have published results that would show either how many doctors or medical practices are actually benefiting from goal carding, or whether there's been an actual impact on the extent to which prior authorization is required. I was not able to find any real data that has been reported out by any of those states. What we do have is some anecdotal reports that have been written up on, and it's kind of a mixed bag. Some people express frustration with it, that it's hard to do, hard to get qualified for. Other providers have felt that it has been beneficial. So I think that one con is that we really don't have any real solid data on how well this works or what impact it's actually having on patients. Next slide, please. So standardized forms, Washington has adopted prior authorization modernization legislation, as have a number of states, and the federal government, CMS, is moving towards that, mostly look at speeding up the process, requiring automation and interoperability, making sure that prior authorization requests can be done online, through APIs rather than faxes, et cetera, and transparency. But an additional improvement that a couple of states have looked at and have adopted is to make sure that all of the insurance companies are using the same form so that providers don't have to worry about, are they submitting the right form to the right carrier? It's just an additional friction point in terms of submitting prior approval requests. Next slide, please. So Washington, we can skip this one. I've already said it. So again, this may reduce in confusion, improve efficiency, make sure that the information will be complete because it'll be the same all the time. On the other hand, it may be that you can't really standardize every request. And I think that the number one issue with respect to standardized forms is even if you have a standardized form, that in and of itself does not require all carriers to use the same criteria as to whether to approve a particular request. So you're getting at one part of the issue, but you're still going to have variation among insurance companies as to whether particular requests are going to be granted or not. So as I indicated, as we were looking at this, and you had in the August meeting a slide that showed the approval rates for various services, inpatient, outpatient, behavioral health, et cetera. And what the report showed is that generally speaking, the approval rates are very high, 95 to 97% and above. So that raised a question for us as to whether it might be possible, rather than going doctor by doctor by doctor and gold carding, maybe you could remove certain procedures and services from prior authorization entirely across the board if it turns out that you're just not getting a lot of bang for the buck, because most of the time, or virtually all of the time, those approval requests are being granted. I see Representative Schmidt, have your hand up.
I do. And when you were studying that percentage rate of acceptance or going ahead with the procedure, did you also take a look at the amount of time that took to get that authorization?
Yes, Jane, maybe you want to respond to that since
Sure.
it's your report.
Sure. So Rep Schmick, this was the prior authorization reporting that we've been doing. We're now coming into our 5th year of the reporting, included questions about how long it takes the carriers to process. So all that's in the report. And I just would note really quickly, the legislature did take a baby step on standardization of both forms and criteria. I put it in here, Section 9 of Senate Bill 6228. OIC and HCA are working together right now, working with the insurers and the SUG residential treatment providers to standardize the authorization process for both initial authorization and concurrent review. And we have a report due to the legislature at the end of the year on that. So it's a baby step, but it is a step on standardization.
Thank you. Representative Riccelli.
Yeah, I just wanted, can you expand a little bit more? Because as Jane will remember, we were looking at things that were potentially like at a 99% level being approved, and how maybe that was, and we kind of steered away for that direction. There were some reasons for that, but can you expand a little bit on that piece?
Expand on what the policy would be, or
yeah, just we got some pushback on that. I mean, it seemed pretty straightforward, and I think it was largely.
okay.
Yeah, go ahead.
Yeah, so I, putting myself in the shoes of the insurance carriers, what I would put forward as a possibility is that the reason the rates are so high for approval is because we're not getting a lot of bad requests, because people know they're going to be subject to approval. So there's a sentinel effect that's happening, right? So that if you did away with prior approval, you might have more, you'd have more services being delivered that might be not medically necessary, because people then, providers would then know that they're not actually going to be subject to review. So I think that one possibility for you all to consider, if this is of interest to you, would be to ask the FTAC to dig into this a little more and get some information from the carriers as to what they see as the benefits of the programs that they're running. What do they cost? What do they think they're saving? Why do they think it continues to be useful to be reviewing services that they're approving at these high rates? To get
And the providers.
And the providers. Sorry, thank you, Vicky. On both sides, so that people, so we can get a fuller sense, as you're suggesting, Representative Riccelli, of why this is, what the benefits are, or the downsides are of continuing to do things the way we've been doing them. Joan, I think your hand was next.
Yeah, thanks, Carrie. This might be a you question, or Jane, this might be a you question. For prior auth now, is there I know with the ICD-10 codes at CMS, there's a certain time of year where we would update, where the updates get made. Is there like a standard time of year when carriers can change their prior auth practices? And then I guess I'm wondering, Gary, this was very specific to standardization of forms. If that doesn't exist already, then I'm curious if like standardization and how you give notice of those changes, or standardization to like create a certain time of year where everyone would know all the prior auth changes are getting made, if that's part of this or needed or already handled somewhere else.
Yeah, so Joan, I can say we regulate a lot about the process, or a fair amount about the process, but we do not restrict the insurer's ability to update their criteria, the clinical standards that they use for utilization review. And just to Gary's comment about the sentinel effect, that is indeed the argument that the carriers made when Rep. Riccelli is referring to discussions that we were having a couple of years ago. And one way to think about that is to have OIC come back if you do want to say, no, we're going to lift prior auth for X amount of time, is to have reporting back a few years hence that basically goes in and looks at what has happened to utilization of that benefit to see whether indeed utilization does increase with respect to services that are no longer subject to prior auth.
Charles?
Yeah, thank you. I was just wondering if any of this, so looking at the standardized form and related information, did that in any way look at requirements or not for standardization of information reporting? So a lot of the complaints I have from providers is just the whole process feels like a black box, right? You don't know the criteria for what is going to get approved or what is get denied, and you don't even know exactly why it was denied. So does this in any way touch that regards to requiring transparency in the decision-making process?
So I think, Jane, you wanted to take that too?
Yeah, Charles, I mean, I can tell you that we at least have rules that require that carriers post on their website what their utilization criteria, review criteria are, what's required to submit. And even if every single carrier is meeting that standard, the challenge is that from a provider's perspective, right, they're having to look at 20 different places to figure out what's subject to prior auth, what the clinical criteria being used are, and what forms they have to fill out. So even though technically it's available, it's still a challenge when you have that many payers.
And I think, sort of anecdotally, what I hear from providers is that a lot of times things get denied only because the right form of words wasn't used, or what the form wasn't filled out exactly correctly, and then, it gets reviewed again, and maybe eventually it gets approved. But meanwhile, there's been delay in providing service to the patient and additional costs and administrative burden and, going through that process. Mohammed?
Oh, yes, thank you. No, this is all great numbers, but I was interested, is there any evidence this actually works in reducing cost, or preventing people from misusing the services they don't need? Is there evidence out there? I also would like to see the numbers from the consumer's perspective. What does it do for the patients that have to wait for all this process to play out?
Yeah, I mean, I think one of the problems that we have is that we don't have good evidence for any of these new policies that have been implemented, partly because they're so new and partly because the data is just lacking. So we don't have a lot of good information on what the impact of any of these would actually be. I will say that in response to all of the discussion about prior authorization, some insurers on their own have been reducing the number of products, of services, that are subject to prior authorization. United Healthcare recently introduced, just in the last few months, a national gold carding program. But there's a lot of skepticism about how well those programs are going to work if they're just voluntary by the carriers as opposed to having actual, regulation to enforce them. Chair Lowe.
So this report didn't include Medicaid, right? Is there a similar report on prior authorizations for the Medicaid managed care plans? I know there's not very much authorization in the fee-for-service program.
Yeah, that's a really good question, Vicki. I know we're not tasked with collecting that. I don't know whether HCA's done a comparable look at the Medicaid MCO.
And maybe,
But I can double check and follow back.
okay. I just think that would be, I'm wondering if they're the same services that are at the top there.
Back.
Okay, thank you.
Well, moving to the next slide, Audrey, the initial question for all of you is whether you feel that you have enough information to make a recommendation to the legislature on whether it should look at gold carding or standardized forms as policies. If not, is there additional information you'd like to have? And then because it came up after the packet went out, are you interested in having the FTAC take a look at this other approach, which would be to look at whether certain services could be exempted from prior authorization due to the high approval rate that they're experiencing?
Gary, I think another question potentially to pose also is, are there particular services where there have been historical access concerns where the legislature, where the commission might be interested in trying to break down prior auth barriers?
Their access is being impeded because of prior authorization with respect to specific services.
Mm-hmm.
Yeah. Charles?
Yeah, I think the last point made by Jana, some important one. And also for gold carding, I was wondering trying to understand how it works. So someone gets approved based on historical performance, but then what is the mechanism for in the future being able to say that the people that are in the gold card program are still the best performers, right? So someone gets gold carded. Does that mean is there ongoing data collection with regards to their practices, and is that still in compliance, or does that mean for life they are gold carded? And then what does that do for equitable access to the program for those who are not yet in the program?
So the statutes do provide for the exemption to last for a certain period of time, and for there to be after some period of time, a review to make sure that there's still good compliance. Nicole?
I guess I was just thinking about it in a little bit of a different lens. My questions would be, are there any sort of guidelines provided for just a standard set of things that are automatically approved or that could be under the authority of a provider to know which procedures are kind of like outside of the pre-auth like criteria, I guess? Maybe would that be like a delegation of authority type decision, I guess?
So right now, carriers decide which procedures are going to be subject to prior authorization and which are not, right? So if you're not on the list of what's subject to prior authorization, then there's no requirement that there be prior authorization. And I think what we're suggesting as a possibility is to reduce the scope of prior authorization by eliminating some procedures that are already being approved at a very high percentage, so that fewer would be actually subject to prior authorization. Does that make sense?
Got it. Yep, total sense. Yeah.
Vicki?
And this came from my dentist, by the way, but she said if it was very clear to her what the criteria were for a specific service, I think this is what you're saying, Nicole, that would be golden. If they knew across the board, if this person has this and that, and they send them for this service, it would be approved. And I think that's kind of the missing pieces that Nicole was asking about was the criteria. And Jane.
So the one place that the legislature has done that is for substance use disorder treatment. It mandates, the legislature has mandated that the medical necessity criteria for substance use disorder be ASAM.
Yeah. Oh, yeah. If they meet the, yeah. And that
Yep.
works. And that's how the fee for service program works in
Yep.
Medicaid, and it works well. It's when people are in managed care, and then the managed care organizations put all these other, but yeah.
Now they have to use ASAM.
Good. So we're asking, do we want more information? Do we want the FTAC to really look at this and see?
So if we go to the next slide, if you're prepared to go forward, we have some potential recommendations. If you feel that you're not prepared to go forward with recommendations and want more information, we'd like to know that so that we can come back to you with whatever additional information you think would be helpful.
So these are do we want to recommend the legislature develop and consider legislation to implement a gold carding program? Do we want to recommend the legislature develop and consider legislation to implement a standardized form for prior authorization across all payers and providers?
Is there something more along the lines of what Gary was suggesting and some of the discussion was focused on? Or do you need to learn more information?
Mm-hmm. Dr. Chima.
Yeah, thank you. So two questions. One is, in the earlier discussion, there was the third option about potentially excluding some services. So I wonder why is that? Is there a reason why that is not part of the recommendation? And then the other question is, are there instances where other states or other authorities have looked at requiring standardization? So part of the chaos as described is everyone's kind of had their own rules as what goes through prior auth and their own criteria. Has there been any instance where there was, expectation that all the players work together to come up with a set of, to say these are the conditions for which we're going to require prior auth, and this is the criteria?
I'm not aware of, there are some states that have adopted gold carding. There are some states that have adopted standardized form legislation. I'm not aware of across, kind of a more blanket approach to looking at procedure by procedure, which, regulating directly what procedures can be subject to prior authorization.
And just one note, in Washington State, withdrawal management and residential substance use disorder treatment, there can be no prior authorization requirement for the first, either 2 days of residential treatment or 3 days of withdrawal management. No, I think it's 3 days of residential treatment and 2 days of withdrawal management. So again, it's the one place where the legislature has said we need to standardize is SUD residential treatment.
And has there been any reporting on that, pushback from carriers? I have a feeling the providers might like that. Is there?
I mean, and the legislation applies across commercial, PEB/SEB, and Medicaid, which is another feature of it, of trying to have as broad a reach as possible. It took a lot of work to develop things, and it's taking a lot of work. The standardization of the process is just happening now, Vicki.
Mm-hmm. Okay.
So it's sort of like the other states, right? These are areas that the states are moving into rather recently. So.
Was it that there was a conference that a couple folks were at. We heard from the state of Illinois on something that they've been doing with inpatient behavioral health. And do you remember exactly what the commissioner there said? That
Yeah, they're
doing?
prohibiting. So Illinois prohibits prior auth for inpatient mental health treatment. And if I remember correctly, I think maybe New Mexico passed a law prohibiting prior auth for outpatient mental health treatment. Or at least, the first X number of visits.
Yeah, along the lines of, I think Rep. Schmick, you asked about, are there certain services that we know folks are having a real problem with?
Mick, you had your hand up.
I do. I'm just curious, did when looking at these proposals, was there any contact made with the carriers to ask them about the cost of changes? Because IT does cost money, and to see just how much it would be if these internally, the cost of these proposals.
Not as of this point, although we could. It's a good question. And if that's something that you're interested in having us do, we certainly can do that.
Can I add something in?
Yeah.
Hey, Representative Schmick, I do know, even with what we have on the books and what's going on at the federal level, that the carriers are going to be asking for some implementation in what we already have on the books being delayed to more align with, because they're concerned they're going to develop something for our state law, and then something new is going to be developed within 12 months after that. So that's what they're.
I was aware of that. I was just asking more about the IT costs that are involved. Sometimes we ask carriers to do something and we don't know. Everything costs money, and especially in the IT world.
I was taken back by when the initial prior auth bill, I don't know if you recall, Rep. Schmick, but they were talking about the number of employees that they were going to have to add to handle a bunch of stuff. So not even just the IT piece, but there was a big mention of the kind of the personnel infrastructure too.
Yeah, it was the personnel to respond to the quicker response times.
So I feel like I'm hearing that we need more information, right? Sounds like we need to know about impact to carriers. Do we need to know? I think we don't know. We do know that other states are doing gold carding, but we don't have any reporting on it, right?
Yes. I mean, we could reach out directly to those states and see whether they have information that's not public that they're willing to share with us. That's something we have not done at this point.
So are people feeling like more information would be good before we move something forward?
I would just like to know if the other states that have done this, have they seen, has it been helpful to the patient? Has it saved money, for the carriers? But I think that's a fair question.
Mm-hmm. So is this like something we're going to send to the FTAC or Gary, Liz?
That would be the easiest way for us to move forward. Yes.
Send these changes or recommendations to the FTAC to drill down on more information.
And then bring it back to
And then
this
bring
group.
it back.
Yeah,
Better
because
understanding impacts of cost to the insurance carriers, providers, do they actually help patients? Is there any?
Well, and I think that, one of the good things about having FTAC grapple with it as well is that it's something to consider for both. Is there something to do now? But also, what is the role that the commission may want this to be in the future system that they're designing? So, but by having FTAC grapple with it next month, we're going to keep moving and try to keep momentum going on the issue.
Dr. Chima.
Yeah, and I also wanted to add to the last question I asked, which I feel hasn't been answered, about the third piece about the conditions for which there is, significant approval most of the time. So how is that reflecting in the recommendations? And is that an area we need more data on that? Because I feel like that's a bit more equitable than just picking a few providers and saying you are exempt. Like picking conditions that irrespective of what provider should be. Is that in competition with gold carding, or could that be implemented in addition to gold carding, for example?
Thank you. That's definitely something that we want to get more information on, both from providers and from carriers as far as what might be doable. The reason it's not on this slide is because the idea sort of came up as we were preparing for the meeting, but after your packet went out. That's the only reason. I think we have some direction. Thank you.
Yeah. Okay with the direction. All right. Thank you. One more topic, guys. So our last topic of the day is tab 11, and it's a discussion on looking ahead at our next steps. So back to you, Gary.
I think actually Liz is going to take this one.
We knew there was a place where we needed to put the right name on it, but I just, before we get going into next steps, and you can go to the next slide, it's part of next steps, but just want to go back to Jane's presentation about the OIC affordability report. And similar to what we just talked about with prior authorization, I just want to affirm with Jane and HCA folks who spoke a little bit earlier that some of the policies that you presented on, Jane, are things that that should be thought of in terms of the future system for a universal system, but also there's opportunity to do something now, and that was the context in which you all were looking at it for OIC right now. And I think, Dave, you mentioned something that is potentially happening with one of those policies now. So I just wanted to pause really quick and ask if you might be able to speak to that for just a second, because it will be something that we want to talk about, both in terms of next steps for universal design, but also for a short-term policy conversation, short-term issues conversation.
Just to clarify, you're referring to the consolidation topic?
I was referring to the affordability.
Okay, that's why those are two things to see.
Just wondering if folks here want to hear more about that when we talk about future topics. I don't know how much people heard about the affordability piece.
Yeah, I mean, I'm happy to have a percent split, but that's something that I'm hearing might be helpful.
Yeah.
Yeah. You're not asking me to do that right now.
No, I'm not asking you to do that right now, but I just wanted to, I'm sorry, I'm making a little hash of this. I should have done it earlier, but just to say, for the commission, just level setting in terms of the report that Jane shared, there were several policies in there that are both things that the commission might want to think about for the future design of the universal system, but also there are potential proposals on some of those right now that are being developed. So I just want to put that out there as we talk about what our next steps are in both of those work streams. So today, Jane talked about some of those policies. She talked about the reference-based pricing, the global budgets, medical loss ratio, reinsurance. One of our questions for you today is, are there things that you heard about that Jane touched on that you want to hear more about for consideration for the design of the universal system? So any of those policies that you might have heard about that you want to know more about, or you want the FTAP to look at for consideration for the universal design?
Well, as to your point, I think it would, I feel confident when my HCA would be speaking about the potential affordability bill that draws off of the OIC reference-based pricing topic. I think that would be something that I would be surprised if people on the commission wouldn't want to hear about.
Okay, and I'm having a little bit of a hard time hearing you, Dave, but I think I heard you say that with the affordability for PEB and SEB that you're talking about, it's sort of an entry point and something that they can look at as taking it as this was it's a recommendation from that. So, okay, so definitely yes. Are there other policies or things that you heard about today that Jane touched on for the universal design that you would like to hear about?
Rep Schmidt has his hand up.
I'd like to know more about the referral pricing. If we're going to do that, we're going to have to make some assumptions because right now it's pretty wide open and very general. It would seem like we need a starting place on assumptions just to even make a good call, so to speak, I think.
Similar to how we talked about the cost sharing, having some principles and diving deep in understanding.
Well, principles or and some assumptions that we can figure against.
Okay.
Because right now
Sounds-
it's pretty broad.
Okay. Any other policies that commissioners are interested in having the FTAC think about for, or if you want to hear about for the universal design?
Mohammed?
Yes, thank you. I actually, it's not about the Jane's presentation, but this is a question that was asked by one of the public comments earlier. Would it be possible for us to have some sort of like a progress bar, like something we could share publicly every commission meeting so that the public can see where we are at in terms of doing what we were commissioned to do, which is, moving the state to universal healthcare coverage. I like all the reports that we get from the FTAC and from HCA and all of that. But would it be possible to basically to also notify the public, continuously about what stage we are on, and for transparency reason, when should they expect to at least see like a transitional recommendation for the state to move on?
I think that HCA, Mary, I can't see your face on here because I'm just on a little laptop, but I'm sure we can work on something like that.
Yes.
Thank you.
Okay. Any other policies? I think particularly, again, we're in phase 1. Anything around provider reimbursement participation, cost containment that you all would like to have the FTAC grapple with? Or that you want to hear more about?
When I'm thinking about this report sorry, I didn't raise my hand. The report that Jane said, and like the really high impact items were supporting the Healthcare Transparency Board work. And do we need to understand that better, or are people really familiar with that? I know I sit on that board and I haven't been able to go to a couple of the last meetings, but are people interested in understanding that better?
Are you talking about the growth benchmarks, or is that different?
Yeah, the benchmark. Yeah.
Yeah.
It was like low high impact, I think, right?
Yeah, I'd be interested in hearing more about that.
Okay. Hearing is early scheduled for December 12th. I'm sure we'd be happy to send a link to commission members if they're interested.
We can't hear you in the room if that's something and you're sorry.
Sorry, the benchmark report public meeting is scheduled for December 12th. I'm sure we'd be happy to send a link to commission members to be able to also attend that meeting if they're interested.
That'd be great. Yeah.
Again, okay, so more about the cost board and the benchmark work that's been done, the transparency work.
Well, I think Mandy's offering for us to like attend the meeting and hear the report and then maybe see if we need to know more.
Okay.
Yeah.
Sounds good.
Okay. Yeah.
Okay. So why don't we go to the next slide? So I think for universal design, we're going to talk more about the reference-based pricing proposal, learn more about it from the FTAC, and also hear about the current proposal that is being developed with PEV and SEB. In terms of transitional solutions, I think we talked about this a little bit earlier. We have some next direction on the prior auth, but also wanted to check with the commission. Are you interested in continuing to discuss another area of administrative simplification, or do you want to move to something else? I heard earlier an interest in talking about the Medicare Savings Program. We did talk about the Apple Health expansion, also consolidating and expanding state purchasing. So just want to ask the commission, is there something else you want to focus on from these original 3 buckets? Or is there something else that is not up here that you want to start talking about in terms of transitional solutions?
With regards to the first bucket, right, the one that talks about interest in preventive and primary care. So one is maybe a little bit of refresher on any decisions or discussions that have been had on that particular topic, if any, and then is there a reason for limiting that to interest versus, because I think a lot of the issues we see in our state is about just the fact that we have limited capacity and we have real access issues to primary care. So could that possibly be expanded to address that as part of the transitional solutions about I know there's a related work with regards to other committees working on primary care access, but could that be brought in as part of within the scope of the transitional solutions is really addressing the need to expand access to primary care?
That is such a great point, Dr. Chima. I actually, when you said that, I realized I'm thinking back to what Jane said about one of the things that that is looked at with the reference-based pricing model was reallocating dollars to certain things, which definitely would touch on that as well. So, but I don't think there's a reason it's limited. So, I think that's something we can talk about as well. Other areas that commissioners are interested in hearing about?
I don't think you can, okay, you can see my hand.
I can see you, yeah. I don't know why people's faces are not showing up all the time, so go ahead.
Well, I don't want to give Dave an ulcer or anything, but I have, repeatedly asked about expanding PEB and SEB to small businesses. But is there another, I think it's some of the pain points in the system, looking at prior authorization, really important, reimbursement to providers. But I think it's like the small businesses that are really hurting in the current system, even though we've expanded access to more people. That's the place where I think a lot of people go without coverage because it's just too expensive. They can't afford it, or maybe those people are getting coverage in the exchange anyways under the QHPs or Cascade Care. But I remember when the Health Plan Finder first rolled out, we had SHOP, which was like an employee plan. And I know that when we had basic health plan, we used the non-subsidized plan as our employee plan until it went away. But I don't know if there's something that we can think about in that way, because that still helps move those people into the same coverage as another group, which is something we're trying to move more groups together, right, to consolidate, but also thinking about how hard that market is.
I think that's one of the things that I remember from the work group that preceded this is that was something that came up quite a bit in that group was how can we make PEB and SEB available to a broader set of folks? And I think you're talking about a very specific population that really needs help right now. And I know Dave's sound is awful. If you can try to talk, Dave,
phone really
but if not, maybe just chat in and somebody can relay your message out.
Well, is this better a little bit or no?
Yes.
Oh yeah.
I'm not sure. You can't see me. I'm just literally leaning into my computer at the moment.
I see your hand. Yeah.
Yeah. I think, Vicki, what I was going to say is understanding the history of the SHOP and its success or the challenges that market faced, even on the exchange, I think is a relevant piece of the puzzle, because what you've described is definitely, there's a history there on challenges that exist within that market. On the PEB and SEB side, one of the things that, I recognize that what I'm about to say, it's a hurdle that has to become over at some point on a journey towards a universal system. But adding private employers directly into PEB and SEB would risk the ERISA exemption that exists for the governmental plan. So, I mean, like I said, at some point that would need to be acknowledged, appreciated, the impact of that understood and evaluated by everyone. But you know, a sibling program, if you will, that's similar to a shop. You know, I think that's always something that could be analyzed and looked at. But I do think it would be good for the commission or all of us to understand the history of on the shop and the exchange and the challenges that exist.
So maybe Joan can help us get that information, or I see Jane's hands up too.
Yeah, actually HPE put together a couple, like a 2 or 3 page brief on the history of SHOP, Vicki, and I'm sure Joan would share that. I think the other thing to explore is, you know, there are a variety of federal kind of HRA options. And so I think realistically, when a small employer is looking at whether they can afford to provide health benefits to their employees, it's sort of what's the array of things that they look at. I know next week we're having our quarterly meeting with brokers and agents, and I'm going to ask them what their ideas are because they talk to small employers every day, and see whether they would be willing to engage in like a separate hour-long meeting just to pick their brains and sort of have a sense of, if I were going to put together a table that had what are my options as a small employer, you know, what would it look like and what are realistic and what aren't. And so I'm hoping we can engage them. And then Christine reached out and said that HPE also has a broker advisory committee. And so it would probably make sense to sort of get comparable input from them, just so we could hear directly to the people who are working with small employers every day. And if we did want to dig in on this too, is asking Patrick Connor to come, because he's long-standing NFIB person on healthcare, to provide his perspective if we want to dig in on this. And I'm happy to report back to the commission anything that I learned from the discussions with the brokers and agents we work with on our advisory committee.
I think that
Yeah, it sounds like a whole kind of, there's a lot of pieces that we would want to touch on in exploring this one. I think Dave also mentioned that they have a report coming out on consolidation in the first place. So looking at that piece, then looking at the shop background from WABI, from the Health Benefits Exchange, and then hearing from what you get from your carriers, conversation and brokers, Jane, and then from Patrick, who was part of the work group. So I think having a whole session focused on that might be really beneficial to think about what options might be available. Okay.
Yeah, and full disclosure that I run a small business.
So you know, right.
Well, I'm just wondering, do we need, I mean, I guess I understand why the premiums are so high and the deductibles are so high, but
Well,
do we need to also hear from the small businesses too? I mean, even if we did something, would they even be interested in it? You know, I know
Right.
that maybe
That's the
some
question.
HRAs and yeah.
So just to make sure that we've captured this correctly, I didn't hear a lot of interest in continuing on other areas of administrative simplification, but I did hear earlier the interest in doing more on prior authorization in terms of asking more questions around exempting certain sets of services, hearing from other states. But other areas of focus of transitional solutions was looking at the interest in preventive and primary care, motivating interest in preventive and primary care, the Medicare Savings Program, and the consolidating and expanding the state purchasing, with the addition of making sure that we're doing something around small business.
And when we were talking about reference-based pricing, is that provider rate regulation or?
Would you say that is, Jane, to some extent? It's one way of doing it, I
Yeah,
guess.
it's getting directly at price.
Right.
Yeah.
And we talked about that one on a part of the universal design, but also something short term that Dave can talk about next time too. So lots of topics to consider at our next meeting. Anything else? I realize we're way over time and it's, people are probably tired from sitting or being on a Zoom this long, but just one last call. Is there anything else you'd like for the HCA team to be working on to bring to you at our next meeting?
When will be the next meeting?
December 5th, Thursday, December 5th from 2 to 5 p.m.
And I'm going to hand it back to you, Vicki. It sounds like also Mandy and the HCA team are going to make sure that you all have information about the next cost board meeting in December, or the cost board meeting in December, to hear about their findings and what's going on with the Healthcare Cost Transparency Board.
Yeah.
And Vicki, Liz, we'll have our auto enrollment report going in at the end of December. So I'm not sure if that's the next meeting or the following, but obviously happy to share that. And
that's another one of the transitional solutions. Thank you so much for bringing that up, Joan.
yeah, happy to brief people whenever it's of interest.
Yes. Thank you.
It's exciting that so many of the things that you all have been thinking that you've been interested in, there's potentially something moving around those. So
yeah, thank you, everybody. This was a great conversation. Again, the recording and summary of this meeting will be on the HCA Universal Healthcare Commission webpage. Thank you to our presenters and everybody for participating in the conversation. As I said, the next meeting is December 5th, 2 to 5 p.m. And I look forward to seeing you there. Have a good evening.